All right, welcome. We're diving into a topic that is absolutely guaranteed to come up on your anesthesia finals, trauma in the older adult. Getting this right isn't just about passing an exam, it's about handling some of the most complex patients you'll ever see. So let's get into it.
Let's start with just one number, 30%. That's the reported incidence of pneumonia in older adults after they break their ribs. And you know what the most common cause is? A simple fall from standing height. That single stark statistic really sets the stage for everything we're about to cover. It shows how a seemingly minor injury can spiral into a life-threatening event.
So here's our game plan. We're going to walk through the classic ATLS primary survey, A, B, C, D, E, but we're going to look at each step through the specific and often challenging lens of geriatric trauma.
First up, let's talk about the fundamental problem. Why are the rules so different for this group? It all boils down to one concept: diminished physiological reserve. Think of it like this. A younger patient's body has a huge buffer, a deep well of resources to draw on when injured. An older adult, they're operating much closer to the edge, with very little reserve to spare.
And because of that lack of reserve, everything gets complicated. All their other medical problems, the medications they're taking, it all conspires to blunt their body's response to injury. This can create a clinical picture that looks falsely reassuring, masking a complete catastrophe that's brewing just beneath the surface.
Okay, let's move on to A and B, airway and breathing. Now for us in anesthesia, this is our territory. But the geriatric airway, well, it presents a whole unique set of mechanical and pharmacological challenges that we have to be ready for.
And here is an absolutely critical high-yield point for your exam. You have to reduce your RSI sedative doses. We're talking by 20 to 40%. If you push the standard adult dose, you risk tipping them into a profound cardiovascular collapse. Their system just can't handle it. This isn't a suggestion, it's a rule you have to live by.
Now remember that 30% statistic we started with? This is why it happens. A seemingly minor injury, like a few broken ribs, can become deadly. The mortality risk literally climbs with every single additional rib fracture, and it's all because of a vicious cycle. The pain causes them to take shallow breaths, which leads to lung collapse, and that sets the stage for a nasty pneumonia. This makes getting on top of their pain early and aggressively one of the most important things you can do.
All right, on to C for circulation. This is where things get really tricky. Recognizing shock in an older patient is notoriously difficult because the classic signs we've all been trained to look for are often completely absent. So you look at the monitor and you have to ask yourself, how can this patient be in shock if their heart rate is normal and their blood pressure hasn't even dropped yet? The answer is that their body just can't mount that classic stress response. Things like beta blockers, pacemakers, or hardened arteries all work together to hide the truth. And this illustrates that difference perfectly. A younger patient's body screams for help with a racing heart. It's like a loud alarm bell. In an older patient, that alarm system is broken. They can maintain what looks like a normal blood pressure right up until the moment their system completely collapses. You cannot afford to wait for hypotension. You have to be suspicious from the very beginning.
Okay, let's move to D for disability. When an older person falls, we're not just worried about broken bones. They are uniquely vulnerable to some very specific and often devastating neurological injuries, even from what seems like a minor tumble.
Now here's another classic exam topic you've got to know cold: central cord syndrome. It's often caused by a simple fall forward, where the person's head gets snapped back. In an older patient who already has some arthritis in their neck, that hyperextension can actually pinch and bruise the spinal cord.
This diagram shows you exactly why the symptoms are so specific. See how the nerve fibers for the arms and hands are located right in the center of the spinal cord? That's the part that gets injured. So you get this classic clinical picture. The patient can often walk, but they have significant weakness or even paralysis in their arms and hands. The little phrase to help you remember is, they can dance, but they can't play the piano.
And finally, we've come to E for exposure. This isn't just about finishing the acronym. It's where we cover some crucial environmental risks and pull together all the key takeaways for your review.
So, exposure means a lot more here than just cutting off clothes. First, older patients get cold, and I mean dangerously cold, very quickly. You have to actively manage their temperature from the start. Second, their skin can be incredibly fragile. And third, and this is so important, you have to be their advocate. If the story doesn't add up, or if there was a long delay in getting to the hospital, you need to have a high suspicion for elder abuse.
Okay, let's put it all together. Here are the 5 high-yield points you absolutely must remember. Think of this as your exam checklist. 1.
Always be suspicious of a hidden injury. 2. Cut your drug doses. 3. Treat their pain aggressively. 4. Remember those specific injuries, like central cord syndrome. And 5. Keep them warm. If you can talk through these 5 points, you're in fantastic shape.
But, we've talked a lot about the physiology and the pharmacology. There's another challenge here, one that's not in the textbooks, and that's the issue of ageism. We have to confront the reality that implicit bias can affect how we allocate our attention and resources.
So, as we wrap up, this explainer has focused on the what and the how of geriatric trauma care. But this final question is about the why. It challenges us to think about the kind of culture we want to create. How can we be the ones to make sure that every single patient gets the absolute best care possible, no matter how old they are? That's a question worth thinking about long after your exams are over.